see I see some of them are present here tonight, is just really a testament of the teamwork that is necessary to carry this high-risk operation on a patient that otherwise probably would not have fared very well, right? This patient would not have been considered for surgery in many other places, but we sort of took each other's hands and then jumped into deep waters altogether, and I think we got a very good success story. So, as I said, I don't want to take too much of the credit, and for that, I'm going to let Lanette lead this talk, and she has a real nice view of her experience. So I'm going to play a video that she has. Although she's right next to me, she recorded a nice video, so we're going to go ahead and play that. But thank you for coming again. So I'm going to share my screen here.
Hello, my name is Lanette Johnson. I've been a nurse for about 14 years now. 7 of those early years, I've been a bedside nurse in pediatric cardiology. In the latter years, I was a nurse practitioner where I'm still actually currently practicing with our cardiothoracic surgery team. This trip in 2019 to Chiapas was my first trip with HeartCare International. I want to thank Betsy and Margaret for giving me the opportunity and everyone else that's involved with HeartCare International. And I also want to thank everyone for giving me the privilege to present this surgical case on this patient that we provided surgical intervention to. So we're going to review this Truncus Arteriosus case. Goals for this presentation are to present to you the overall Truncus Arteriosus, the pathophysiology, early treatment options in the first weeks of life, and how very different and almost challenging this was when we met Ivan, which you can see pictured here. We'll also review Ivan's clinical practice, surgical interventions performed while in Chiapas, our postoperative complications, along with some of our barriers that we had. We wouldn't be presenting this case if it wasn't for the achievements that we had while on this trip. Lastly, overall, I do want to give you kind of a nurse's perspective in a ways to just challenge our nurses that are working at the bedside now. So first we'll go over some pathophysiology. To understand the pathophysiology related to Truncus Arteriosus, we first have to understand the path of blood flow and its anatomy. This is something that I focus and stress upon as a nurse practitioner when doing preoperative teaching prior to my patients coming to the OR. In Chiapas, this was already nicely done in a clinic setting by both teams. Again, as a nurse practitioner with the surgery team at my institution, I have to understand this knowledge that my cardiology colleagues are giving to the families and then present this information to the families while also giving them the surgical intervention and what to expect postoperatively. Many of our families aren't meeting the surgeons at all until the morning of surgery. And so I know that I've done a good job when they meet the surgeon the morning of surgery and they can tell him what he's about to do. This is all what I like to also consider is meeting the families where they are in their child's diagnosis. Some of these are new diagnoses, some of these are urgent, some of these are postnatally diagnosed, and some of these are to people that are speaking languages not our own. For patients with Truncus Arteriosus, the systemic venous blood normally returns from the right atrium and flows into the right ventricle. Pulmonary venous blood flows from the lungs, normally flows through the pulmonary veins into the left atrium to the left ventricle. This is all normal blood flow. The congenital malformation is the single arterial trunk that arises from the heart and overrides the interventricular septum. The VSD allows oxygenated and deoxygenated blood to mix before it's ejected to the common truncal valve to a single great artery, which supplies the coronaries, the pulmonary, and the systemic circulation. I've included a picture here of just normal heart and the Truncus Arteriosus heart. A lot of times we'll go over this with the families too. It gives just kind of a good visualization of what the blue blood looks like, what red blood looks like, and then where the mixing is. And this gives us an opportunity to be able then to describe and explain to families what we'll be fixing and how we can do these surgical interventions. Throughout fetal development in the first weeks of life, the pulmonary vascular resistance is relatively high in Truncus arteriosus, resulting in a greater shunting of mixed oxygenated and deoxygenated blood into the systemic circuit, sometimes causing mild stenosis. With the pulmonary vascular resistance dropping, the pulmonary blood flow increases, and we see pulmonary overcirculation, which can lead to congestive heart failure. If this is left untreated, the pulmonary overcirculation can lead to severe irreversible pulmonary vascular disease. This can lead to pulmonary vascular disease as it worsens, that pulmonary vascular resistance increases, and this leads to worsening cyanosis or right to left shunting. Over time, this can really challenge that balancing of QP and QS. Again, the life of a nurse practitioner, kind of taking that physiology and putting it to practice. If we take these quick kind of basic knowledge that we have of Truncus arteriosus and that pathophysiology, we can kind of drive and see what our clinical picture is going to be. So a lot of times I try to remind new nurses and nurse practitioners to really ask, what does your patient look like? I've included again those same two pictures just so you can get an idea of what Truncus arteriosus in a normal heart looks like. And then on the right there, you'll see the different types of Truncus arteriosus. I'm only going to focus on that type 3, which was Ivan's type, Truncus arteriosus type 3, where you see a widely separated pulmonary arteries arising laterally from the truncus. The next couple slides here I have termed first steps, single steps, and next steps. As we discuss Ivan's case, we'll be going over some of those clinical findings, and that presentation is going to be very different from sometimes how we operate in the United States. This highlights again just those difficult decisions that were made for preoperative decisions and kind of just what to offer him as an intervention at all. Clinical manifestations typically become apparent in the first weeks of life. If it's not already prenatally diagnosed, typically at birth, you're going to hear a murmur, you're going to see some tachypnea, some costal sternal retractions, sweating with feeds, and then this eventually lead to failure to thrive. Typically, a complete repair is performed in the first 1 to 2 weeks of life. We also can offer options like banding, doing bilateral pulmonary artery banding, if we have a lot of multiple complexities with the patient or there's any kind of genetic concerns that we're trying to figure out. So quickly, just some statistics I have here and some data. Without single stage repair, patients often die before 2 months of age. The 1-year survival rate with unrepaired patients is less than 10%, and this is all from the STS. The 1-year survival rate, again, listed there, is less than 20%. By the age of 4, pulmonary vascular obstructive disease becomes so severe that a lot of times surgery is futile and these patients will die before the 2nd decade of life. Some later post-op complications after surgery. We'll a lot of times see as the patient ages, they're outgrowing their conduit or their truncal valve insufficiency can worsen. We can also see pulmonary stenosis, which leads to pulmonary rehab in the cath labs. By a 10-year postoperative period, approximately 75% of patients will need some amount of re-intervention, again, whether that's an RV to PA conduit exchange, valve repairs, valve replacements, PA rehab. If there was any kind of aortic obstruction, sometimes relief of that. And again, this is why it's all just very important for these patients to follow up with cardiology as they grow. So here we have Ivan, our patient. Back in 2019, he was a 5-year-old boy with a beautiful smile. This is a post-op picture. He's a very happy boy. His height and weight are listed here. His height was 104 centimeters and his weight was 14.5 kilos. And again, this barely put him on a growth chart, if not at all. His weight was in the 100 percentile, or I'm sorry, this 0 percentile. He was not even on the chart. And his height was in the 2 percentile. Again, I listed his diagnosis here as that type 3 and some issues before we knew we were going to be battling was that pulmonary hypertension. Just going back to just our basic pearls of cardiology, over time we know that we're getting too much blood flow to the lungs and too little oxygenated blood to the body. Our next steps are sometimes our only steps and definitive steps, if you will, is surgical intervention. So the surgical intervention that we offered for Ivan was a complete repair. This was a Rastelli type repair, which required patch closure of the VSD, detachment of the pulmonary arteries from the truncus, and establishment of a right ventricular to pulmonary artery conduit with a valve homograft. The RVDPA conduit required placement of the proximal end of the conduit over the ventriculotomy to the right ventricular free wall. So for Ivan, this was all done with an 18 millimeter valved fresh autologous pericardium conduit that was made on the back table by Dr. Juan Leon, while Dr. Sergio Carrillo made a Gore-Tex patch for the VSD and immobilized those pulmonary arteries from the truncus for the newly crafted RVDPA conduit that would be placed. Also doing an end-to-end or a direct anastomosis of the aortic arch to the truncal valve. Truncal valve at the time was assessed during surgery to find no stenosis. There was also a 4 millimeter ASD that was created as a pop-off to kind of help with any pulmonary hypertension. I listed here the bypass information for you as well. The total bypass time was listed at 221 minutes with a cross-clamp time of 119 minutes and an antegrade cerebral perfusion at 43 minutes. This provides brain perfusion while the rest of the body is on circulatory arrest by sliding that aortic cannula up into the innominate artery, typically clenching down on that innominate and other head vessels to ensure that there's good flow to the brain. The next couple of slides, I have just some pictures of the team that was there. Again, this is kind of the surgical team. You can see both surgeons in the picture and just kind of the sterile equipment that was brought along before they started. This is your perfusion team kind of hard at work, just getting those supplies all ready and looking to see what they might need. And again, you can see both surgeons there with that patient successfully on bypass. These pictures are that conduit that's being made. If you look very closely at that picture on the left, you can actually see the valves that are there, and then you can see it being slid over that 18 millimeter dilator before it's being placed in the surgical field. The next couple pictures, again, I just have here the surgery team and then some of the team that would have been in the ICU. I was with Heart Care International. And just want to stress the importance of having a good handoff. And I thought this was very nicely done from the teams, from a multidisciplinary rounding and handoffs in general, just from day to night. And just having a team too that is a different language and grown. So having an English team, having a Spanish speaking team, certainly could have found some challenges, but I think overall we did a very nice job working together throughout the whole week that we were there. For your nurses there, you see us with some coffee. So, you know, what do we do while we're waiting for a long surgery? We get coffee, of course. This is not certainly all that we do. During that day, we spent a lot of the morning helping the hospital staff just kind of tidy up the ICU and get patients moved out of that ICU setting to a step down, and kind of waited while we were waiting for Ivan's case to finish up later that day. We also recovered at least one other OR that day. And I think most of you that were there on the trip, if you're able to listen in, will agree that this was a very challenging case to kind of manage postoperatively. And I'm going to go kind of over his course day by day. These next couple slides just kind of go over some immediate postoperative management. Just in general, for Truncus Arteriosus, you may have some complications with ventricular failure. You can have left ventricular volume overload, and this can occur secondary to any kind of truncal valve insufficiency. Your right ventricular systolic dysfunction may result as right ventricular afterload mismatches with that high pulmonary vascular resistance with patients with pulmonary hypertension. Whatever those challenges are that you have from a cardiac standpoint, you're also managing fluid and electrolytes, sedation and pain control, respiratory control, renal and neurological status as well. It's also important to remember infectious control and also providing good nutrition as soon as you can get those things available. And then also having different monitoring. You know, at your very basics, you want to have that non-invasive of a heart rate, a respiratory rate, O2 sats. You know, you want to hope that your heart rate is going to be sinus, and that's a good indicator of just overall cardiac output postoperatively. Invasive pulmonary and arterial lines are also very good for some close monitoring and continue monitoring through this ICU settings. These are just some complications that you might see requiring surgical reintervention on these high-risk patients. Again, you might have some mediastinal bleeding, cardiac tamponade, pleural effusions or pneumothoraces as the patient goes through those first few days after surgery. This is actually, excuse me, a note that I use, or a post-op recommendation note that I use at my institution. This is a common note that I'll use that just kind of looks at that basic system approach. And it also kind of recaps what the patient and what changes have been made with the ICU team from a day-to-day, from a surgical perspective. Our general workflow is that when the patient leaves the operating room, they go directly to our CTICU with our team. That includes our anesthesia, our perfusion team, our OR nurses and surgeon. They will go up and do a handoff to the ICU team, which again will include your respiratory therapist, your bedside nurses, your intensivist, and then usually a charge nurse is available as well. So we're kind of going through all these things and making sure that we check off all of our boxes and answer questions for each other. And then typically, once that's all done, we are letting the families back at the bedside. So this is how Ivan arrived back to the ICU from the OR on that post-op day 0. He arrived to that ICU about 16:47 in the evening. I'm going to kind of go through just systematic-wise how he arrived and what we were watching for. So he arrived from the OR intubated. Again, pulmonary hypertension was kind of our biggest challenge as expected. In the United States, severe pulmonary hypertension management, we typically will use multiple agents together for treatment. A lot of times we're using inhaled nitric oxide, medications like continuous IV infusions like Flolan, sometimes sub-Q Remodulin, oral options of sildenafil or tadalafil are some examples. We could probably spend an entire lecture just talking about pulmonary hypertension management. I won't go into a lot of detail with that. But in Chiapas at the hospital that we were at, we had limited options. We relied very heavily on rectal and then at one point NG sildenafil, oxygen, and sedation. So when he came back to us from a respiratory standpoint, he was intubated. You see there, he was on 100% FiO2 that night. We did leave him intubated, sedated, paralyzed, and kind of treated acidosis. He was started on sildenafil rectally. And we kind of crossed our fingers, and as we approached that kind of post-bypass slump that, you know, we were watching for any changes in cardiac output and the other things that I listed earlier. And of course, things happened right around shift change. From a cardiac standpoint, again, at that shift change about 1900, he basically coded. I can't remember all the actual details of the drips that he was on, but I can tell you that those moments were intense with intensivists staring at surgeons, surgeons staring at the intensivists, and kind of eyeballing and seeing what do we need to be watching for and doing. You had a couple nurses up at the head of the bed giving co-dose EPIs. You had your RT up there as well, just making sure that that ET tube was secure. And then we also had some nurses at the foot of the bed where we kind of realized we were getting into some tamponade physiology, and we realized our chest tube output had dropped off. So we started stripping those chest tubes. And within a matter of minutes, we had some massive bloody chest tube output from all 3 of those chest tubes. Again, some intense moments of surgeons and intensivists kind of looking at each other and trying to decide if we needed to reopen and explore the chest at the bedside. Fortunately, it did not come to that. Just with that tremendous amount of bleeding, the team did an amazing job giving what they had available. Again, they had Nova 7, which was giving ×3. A lot of times we will utilize cryo and platelets and other factor products postoperatively in our institutions in the United States. The blood banks in Chiapas were very limited on some of the product availability, but again, we did have some factor concentrations, and the teams from both sides were very comfortable with giving those together. Again, this is just another kind of close-up picture of his respiratory support with his ET tube in and making sure that that's secure. Again, I'm going to look at just his lines and everything that he has in. So he does have 3 chest tubes in place. He has a mediastinal chest tube and a right and a left pleural. So you want to really watch those outputs throughout the evening hours and those first kind of 12 to 24 hours after surgery, and watching for any significant output or any drop off. He also had a right femoral arterial line placed during the OR, and he also had a left femoral CVL, which I believe was a double lumen, and then also had a couple of peripheral IVs in place. The next couple pictures are just some pictures of some of the imaging that was available to us as well. Again, a lot of our patients, when they're arriving up to the ICU, are going to get a chest x-ray that's going to look for your ET tube placement and other lines. A lot of times we'll get an EKG as well when we left the operating room. And then also just having an echo available if you need to look at things or reassess things through the evening. When it comes to medications and access in general at the hospital in Chiapas, this absolutely blew my mind. The nursing staff routinely pulled up their own medications and labeled all of their own medications. I cannot tell you the last time as a nurse, either as a bedside nurse or as a nurse practitioner, that I didn't have to rely on a pharmacist to be there either for a code or just giving my medications to me that I can easily sign off. So this was very remarkable to me that they did this all and did some double checks on each other and then had everything ready. And again, I'm not going to go over these individually, but you can just kind of see he was on quite a lot of medications post-operatively, and we'll go into some of those drips as we talk about the next couple of days for him. Again, this is a picture of Ivan just as we continue to talk into those days. That post-op day 1 into post-op day 2, we really didn't do a whole lot of changes. We kind of just stayed the course, minimal changes, minimal adjustments were made as we went into the weekend. And at this point, this was where I left. I left on that Friday, and so this is how I left Ivan. And I know there was some parts of the team that stayed later into the weeks, and we got quite a bit of updates, which I'm going to go through all those with you as well. So post-op day 3 was on Saturday. So we made a lot of good progress. We were able to wean his vent. His FiO2 was down to 50%. He had some left-sided atelectasis, which improved with positioning and just gentle CPT, albuterol, and hypertonic saline nebulizers and methylpredverse. He did have one pulmonary hypertension exacerbation that was noted with suctioning. So the nurses there in Chiapas were just advised to try to pre-oxygenate before they did any suctioning. His right chest tube was removed on post-op day 3. O2 sats overall between 90 and 94%. As they kind of planned their day into the next day on post-op day 4, the plan was to wean his FiO2 to 40% and then start working on his PIP and PEEP and getting ready for some spontaneous breathing trials and extubate by Monday. At that point, here's some of those medications and drips that are listed. He was off his vasopressin, off norepi, decreases epi to 0.025, and his milrinone was planned to stay at 0.5 through extubation. Sildenafil was originally given rectal, and I think it went to NG. They decided to switch it back to rectal because there was quite a bit of NG output, and he had some hypoactive bowel sounds since there was no feed started yet. And then his Lasix also was titrated throughout this from 0.1 milligrams per kilo per hour down to 0.02 and then to Q6 dosing. He overall was very negative or euvolemic throughout the whole process of that week. His creatinine was at 0.6. At that time, as they were trying to wean his vent as well, they lowered some of his sedation and his dex. And then also he had completed his preoperative antibiotics at that point, and blood cultures, I think, are routinely done there, and those were negative. On post-op day 4, Ivan surprised everybody by deciding that he was going to self-extubate himself in the middle of the night, which is quite typical when we're taking care of some of these pediatric patients, but he did quite well. He was able to go to a face mask of 10 liters at 100%, and his sats remain in those low 90s. Chest x-ray by that next morning, he had no pleural effusions and no pneumothorax is noticed bilaterally. He had finished a course of steroid dosing. And again, his milrinone was still kept on at that 0.5, and his sildenafil was still at that Q8 dosing. He had an echo on that day that showed good function. The branch PAs did show somewhat of a gradient, but overall he had trivial tricuspid, trivial TR, and bidirectional shunting across the atrial communication that we talked about, where he had that pop-off valve that fenestration created, and no pericardial effusion noted. I listed some of his vitals here. His blood pressures were quite stable at 120/70, heart rate at 120, and CVP at 10. At that point, he was off all of his pressors, and his Lasix was weaned to twice daily. The rest of his wires and his mediastinal and left chest tube were removed. He did have a little bit of challenge with withdrawal as they were weaning that Dex and some fentanyl. They at one point started him on clonidine as there were no oral opioids available. And he was awake enough and tolerating enough to drink some sips of water and doing well from that standpoint too. By post-op day 5, his remaining chest tubes were removed. He was transitioned to 2 liters of nasal cannula. His methylpred had been stopped. He was drinking well without any kind of emesis or vomiting. He had remained afebrile. He did have a rising white blood count at one point, which restarted antibiotics, but ultimately his cultures all remained negative and there was no further concerns. His incision healed quite nicely throughout that week, and he was slowly being delined. So there was a lower concern for those kind of things as we were watching. This is a nice little picture of our young man. This actually is a picture from when he was seen last week in Chiapas with the group that was able to go back down. So this was 2 years after his surgery. He was discharged in about a week after surgery. So again, just an overall applaud to the team together that were able to get everything coordinated for this young man and get him home to his family. The next couple slides, I just want to applaud the nursing staff at the hospital and give them some of my personal stories of being a nurse over the few years that I've practiced. This is a picture, again, that same picture of Ivan and a picture of his mother. For me, this was a pretty tough thing for me. This was my first trip away and doing care with heart care and just doing a mission trip, medical missions at all. I am a mother and I have two young children at home. So leaving them to go on this trip definitely taught me a little bit more of that motherly love and just trusting others. In my institution, we strive at providing family-centered care. Parents are allowed at the bedside 24/7. At this pediatric hospital in Chiapas, parents were allowed to visit, or just one parent for that matter, at the bedside for about an hour a day. And not that this is necessarily a bad thing. This may just be more related to the fact that just from our infection control related or patient safety, because as you noted in a lot of those pictures, the rooms were all completely open from one bed to the next. But this really does challenge the bedside nurse to not only provide that medical care, but also providing patients with that just parental touch. The next couple slides too. The other thing that made it very easy for me is that they had paper charting. So I never had to rely on a computer that whole time, and I have very limited Spanish. It was very easy for me to go from one bed to the next and look at what they were charting and understanding, and just kind of looking at those totals of chest tube output or what medications that they were giving, urine output, all of those kind of things were just easily there. When I first started as a nurse, I did a lot of paper charting and quickly went to computer stuff. So it's kind of a lost art to learn to do things just simply by pen and paper. And the other thing I like to remind people is just the simple fact of play with patients. We work in a pediatric institution. It's always important to just provide some amount of just normalcy for these patients as they, depending on what ages they are and interacting with them. And those will go a long way in just overall care for these patients and how they recover. These next two pictures, this one on the left doesn't look like a lot to you, but this almost made me laugh out loud when I saw it, because this is literally the picture of advanced as tolerated when it comes to a diet. You have your water, your broth, and your Jello. So this was out on all the patients that were old enough to eat. And so the nurses would, if they could drink the water, they moved on to the broth, and then they moved on to the Jello, and then kids could eat by mouth. A lot of times I feel like we will neglect just nutrition in general for our kiddos. So just continue to remember that is an important factor for healing. It gives patients a lot of autonomy to be able to do things on their own. The other thing I like to remind families preoperatively when they're coming into the hospital from home is to bring things that are familiar for the child. A lot of times our babies might not eat well, and maybe that's just simply because this is not a bottle that they're used to. So those kind of things I'll go over with my families preoperatively, just so that they have a lot of familiarity. I can't talk anymore with that word, but you guys get the gist. The last kind of slides here again is just that continuing of education. And this is a couple pictures of some of our intensivists and some of the ones that I worked with through that week. You can see Michael on the left doing some education with the staff, which was quite appreciated, I think. And he went over just basic physiology on different diagnoses through the week with both the staff with Chiapas and then those of us with Heart Care International. And then you can see the bedside rounds and how many people were involved with these patients as well. So again, you've got your surgeons at the bedside, you have an intensivist, you have a multitude of other people listening and learning. And I felt it was very comfortable for anybody to kind of speak up, even given the language barrier there at the hospital. This last picture is a picture of me. It has been quite a long time that I have worked a night shift. I'm quite comfortable working on a day shift with the surgical team, but I think the one evening I sat there, I sat and kind of stared and made sure that nothing crazy was going to happen with Ivan, and just watching. It looks like a quiet scene. I will tell you it was not. There was a lot of little hustle and bustle, but there was also a lot of, again, giving patients some time to rest. So the nurses did a really good job, as well as lowering the lights, being attentive to all the patients that came back. And this was quite full with all the patients that we did throughout that week. There was quite a few surgical cases and some cath cases. I added this kind of a quote here from a nurse leader, and just to remember that nurses are stepping forward to become leaders, and people are understanding that nurses are not just functional doers of things, but we're also thoughtful strategists. So just remember to include them in your talks and conversations, as well as they continue their education for patients. That is all I have for the evening. If you have any other questions or concerns or comments, I will stop sharing my screen and we will kind of talk about his overall care as he's received in the last couple of years. Thank you.
That was outstanding. And Lanette, super job.
Thank you.
And again, I think it really shows the tribute of us working together from multiple different people from the United States and from the group in Chiapas and Tuxtla. It is an amazing place. You guys have such incredible people there, and we love coming down there. And we're looking forward to coming back. Our plan is to come back in February and then again in September. We want to have you guys grow your program so that you're doing 200 surgeries a year, hopefully in the next 5 years, and you have the people to do it. You're exceptionally, at your medical care, from the nurses to the allied health providers and the physicians, and we look forward to working from you. And it's a tribute to the group from Heart Care that goes down there to help educate and work alongside these people. And Lanette, amazing job. Sergio, great job. I am going to share a video. Unfortunately, Juan couldn't participate today because he is giving grand rounds at his hospital. But I'm going to share a video that he prepared.
Hello, everybody. I'm very sorry I couldn't be present. Sergio and Lanette have done an review, and from this case, and I don't want to become repetitive, I wanted to emphasize just one little aspect of the surgery that I was able to do and to collaborate in this surgery together with Dr. Daniela Miranda. We built a pericardial conduit. This is very, very important, I think. It's a contribution from an Argentinian group from Schichter and Kreutzer many years ago, and unfortunately it hasn't been adopted in worldwide. I don't know why. People are just always relying on synthetic conduits or homographs that, in my opinion, by far are not so efficient as these pericardial valve conduits, and the economy involved is well, you can't deny that in the third world countries where we do surgeries, we have to bring solutions that people can do and reproduce. They are very limited with resources, so we don't have any homographs and will not have in the next years, for sure. So these techniques like the pericardial conduits, and also what we did last time with Parker International here in the DR about the Osaki reconstruction of the aortic valve, those are really, really things that we should explore and teach the different groups in Latin America and the world. So I will start now my presentation, and it's about pericardial valve conduits that we did in this patient in Ivan. We constructed an 18-meter conduit that is still working now. It's out almost 3 years from the surgery. The conduit is working perfectly. I'm very surprised that the valve is still working also, because that has been the downside, or maybe the weak side of this conduit, is that the valve tend to disappear, not to stenose, but to disappear in a short time. So in about 6 months, gone. But in this patient, in all these years, it's still working perfectly. I'm very surprised also that he had a branch stenosis, which is very rare when you use these conduits, these larger conduits. And you have branch stenosis when you use the smaller size as the 12 millimeter, but when it's 18 millimeter size, it's very, very rare to have stenosis. But I guess with this pathology and the lack of space between the big new aorta and those abnormal pulmonary branches, that's why he needed now stents, and I hope he's doing better, and that's all that he needs. So in my presentation, I will start with pericardial conduits. As I said, this is, sorry, it's the first time I do this kind of filming with Zoom. But as I said, the wonderful team that I work with, Sergio and Daniela, of course, Betsy, and the whole team was at that time involved with Ivan surgery. And this work is based on what the group of Kreutzer in Argentina was developing many years ago. That was the first paper. And they even published in the year 2000 a 15-year follow-up of 82 conduits, which, as I said, the large ones are still working. Some of them grow or dilate, and the valve is gone, but they work perfectly well. So in comparison to other grafts, it's very, very efficient graft. So they only had 3 late dates, and they increased the diameter between 1 and 7 millimeters with the years. The 18 millimeters, you don't have any larger problems. So, or conduit-related reoperations. No conduit has to be replaced. And freedom from reintervention at 5 and 10 years is 92.76, and 100% at 10 years for conduit larger than 16 millimeters as freedom of replacement. So that's incredible results. The size of the conduit is very important. In the beginning, when I started this conduits doing but I learned first with Christian Kreutzer in Boston at the Prax laboratory with plastic one time, and then I went to Guatemala, and as Pablo Castaneda asked me to do for the first case, it was a Truncus Arteriosus also. I did. We cut this part of the article, and we put it on the wall of the operating room where we had all the different diameters, the width, the height of the valves, the base, and the weighted base, so that we could reproduce exactly how this group was doing. So now, after doing, I think, over 200 of these conduits, I don't need any more this table. I can reproduce them very easily. That's what we did also in Chapel. I didn't have the measures, but it's very, very easy then to know where you place your leaflets and to solid them on the conduit. So that's for the beginning. It's very useful. So this is autologous pericardium extracted for the patient. So when part of the team is just cannulating the patient and closing the VSD and doing the intracardiac work, one or two person can sew this conduit, do it very easily, and it's done in about 30 minutes. Is finished the conduit. So this is the place where the valves are going to come. This is the conduit per se. These are the valves over, and that's going to be attached with the 7-0 suture, Proline suture, cutting right these edges and giving this valve the form of a big leaflet valve, as you can see here. And then you put it over a Hagar dilatator and you sew it together. Going to be to the PA branches, and this is going to be to the infundibulum. If the patient doesn't have a pericardium because of a previous intervention or whatever other reasons, you can use other materials. I used a core matrix as an example, as this one. They are also very, very good ones. I have very good touch with these ones. I can complain, but also it's the same fate of the valve are going to disappear in a next month and just leave an open conduit. This is a picture implant in the conduit in the heart. First, you go to the pulmonary arteries, to the branches, and then you sew it in the heart. And this is the conduit at the end of the operation. As you can see, it's full bending and doing the work. The valve is here inside, working perfectly. So it's a great solution I find for these patients. So I will try to finish presentation. You will soon either here in the DR or in any other medical mission that we're going to do next year. Thank you, and take care, please.
Well, that was outstanding, and really shows the incredible skill and people coming together as a team. And I think that's what this really shows, is what an amazing group of people. And before I do that, I am frantically sending myself images. I just think it's worthwhile to see what happened. So he came back for follow-up with us, and he was doing exceptionally well, except we did an echo, and we were able to see that he had some branch stenosis. And so here is his echo image, and what you can see is the branch PAs are very small. And the other aspect of this child that was is he didn't have very good PAs to begin with, and had small branch PAs. So he was taken to the cath lab and had bilateral PA stents placed. And then this is the result that you can see that he has these small PAs in the cath lab. And then this is the final result. They had bilateral kissing stents that were placed, and he had a great result, which is amazing. And really, the other aspect of it is he did very well. And now I am going to share 2 videos from him when I can find them.
Pues hola doctores, muy buenas tardes a todo el equipo de doctores. Quiero darles las gracias en este día por darme el apoyo, por brindarme el apoyo. La verdad nos sentimos muy agradecidos, mi esposa y yo y mis hijos. La verdad nos sentimos tan agradecidos. ¿Qué más podría decirle más que seguir ayudando, apoyando a la gente humilde como nosotros? La verdad es algo admirable. De todo corazón les deseo sigan apoyando a todo el grupo, así como el grupo de comités y todo lo que llevan a cabo todo este proceso. Sé que no es fácil, es mucha responsabilidad para todos ustedes, pero en verdad de todo corazón les deseamos que sigan luchando como nosotros. Yo sé que no hay palabras, pero sé que tarde o temprano Dios les va a bendecir. Entonces, ánimos a todos y no me queda otra cosa que decirle más que gracias a todos. Muchas bendiciones a cada uno de ustedes. Aquí vamos a seguir luchando. Gracias.
I think hopefully most people understood what was said, but the gist of it is they're exceptionally thankful for what they have done, what we have done for them, and that his heart's doing well. And then there's another video that I want to share that of him speaking, and then there's a letter that they would like to be read.
Buenas tardes, aquí en mi casita, recuperando un poquito, y aquí ando jugando mis salditos, y ya puedo mover el brazo un poquito,
Demuéstralo.
y el pie.
Gracias a todos, dile.
Gracias.
So if you could read the letter from the family, Mariana.
Hi, everyone. I'm going to read the letter that the father sent to me. To all the members of Heartcare International that helped healing my kids' hearts, I have no words to express how I feel. This experience has been life-challenging. If it wasn't because all of you, my son wouldn't be alive today. I am grateful that organizations like this exist. First, the surgical repair, and then the catheterization. The whole team is amazing. My son could not have been in better hands than yours. We are proud of you. Thank you for looking after the ones who have the need. Keep on fighting just like we do. God bless you all. Thanks, everyone. Love, Ivan, my wife, and me. That's it.
Very beautiful. And really, from my standpoint, there's really not much more to say. However, I do think there's some important takeaways from this. It's teamwork is number one, and working with a very dedicated group of people, both that come from the United States, but the local team to do this surgery. And it takes a village to raise a child. And that's what's happened here. I am, would like to ask the question, and, I know Juan isn't there, but really just an open question. We have been doing since 2006, these high risk patients that have pulmonary hypertension. And we've been giving them sildenafil. Question came as using sublingual sildenafil, but it really has had an impact. We did 3 surgeries in patients that had pulmonary hypertension a week ago. All 3 of them have left the hospital on sildenafil, but it really is a way to manage these patients. And so, Sergio, if you could comment on that, and or Lanette, what your thoughts are. You've worked in Guatemala and see these patients, and we really have to learn from what we're doing in these countries and taking it back to our patients in the United States.
So yes, thank you, Alistair. Yeah, indeed, I think it's the challenging part of all of this is not the surgery itself, as you pointed out, is the management of pulmonary hypertension. And what strategies do you have to carry out, a successful outcome, right? Getting them first out of the first 24 hours, which is the most critical portion, I believe, and then the next 72 hours, and then so forth and so on. But it's essentially a lifelong disease, right? And it's one thing to get them out of the hospital with medications, but what do you do long term? Do you keep them on those medications? And the ideal thing would be to wean them off and have normal pulmonary artery pressures. The only way to do that really is with early detection, I think, early treatment and early corrective repair. When you're faced with somebody that is at the late diagnosis, the late presentation, and the late surgery, it becomes very difficult to manage pulmonary hypertension, and that is really the crux of who to operate and who not to operate. Moreover, whether there is already pulmonary vascular occlusive disease, whether that is irreversible or fixed pressures that are not amenable to treatment, and those patients will never have the opportunity to have surgery. So I think, in essence, I think if we can improve our diagnostic methods, somehow catch these patients at a sooner time, it's beneficial. But at the same time, those that present late, should not be they should be considered still.
But not to be a contrarian, I agree with you completely. However, you and Juan led a team that has really changed the whole trajectory of this child's life by taking a child that would not have been operated in the United States, doing an innovative surgery that would not have been done in the United States. And this child has a normal RV to PA conduit, has normal PAs, and his PA pressures are fine, and he's growing and thriving. So somehow we're missing the boat on where we can operate and not operate. Mm-hmm. I do think using sildenafil and those type of measures perioperatively has been beneficial. So I do think it's, there's more to this, and I think it's a huge tribute to the team that this kid is doing so exceptionally well. And he went home in 5 days.
Yeah, that's amazing. As you know, the STS, the mortality for Truncus Arteriosus is 10%, and the length of hospital stay is about 2 weeks. Now we're talking about usually neonates, right? Infants. Yeah. But yet, I mean, he left with that amount of pulmonary hypertension. He coded maybe 10 times on me. I mean, we use epi spritz like if we were watering the flowers. It was really amazing that he came through. But yeah.
But that's a tribute to the team.
Totally.
And,
totally.
I think the other aspect of this is what it teaches me is that we have an amazing group of people that we're working with, and we're able to take on these high risk cases on a selective basis and have impact on a family and a society.
And yes, one more point I'd like to make is, so the discussions prior to the surgery we were all part of it, but more importantly, the local team, we as foreigners or visitors, if you will, we were like, we want to involve the local team because they will be the ones managing this patient, right? We can do the surgery, that's not a problem. But keeping that patient, in good state of health and, carrying through with the medications, as you're saying, the treatment regimen, the visits, the outreach. Some of these patients, as you said, I've been in Guatemala multiple times, I live there. Trying to get to these remote places, contact families, bring them for an echo. It's not easy. So that is a true testament of the team approach and the local team that has been strengthened by our visits, by our input, and by our suggestions, of course.
No, and I agree with that. And now I have to say, what an amazing job. And, Juan and Sergio, incredible leadership in getting this done. And Lanette, amazing presentation and great leadership on your part to really work with the local team and help them. And then the local team, what an incredible job they did and the management of this child and where he is now. I mean, it's just incredible to see his development. And that takes me to, I would like to ask Ibrahim his thoughts. Has done some high-risk surgery in Peru where that child has done well and needed reoperation. And overall, what is his thoughts looking at this patient and then the patient he had done in Peru and how we can do things better? Ibrahim, you're muted.
Sorry, I'm in an airport in Saudi Arabia right now. So that was an amazing presentation. I caught the latter part of it, and I'm so excited to learn more about the conduit that Juan showed, the technical aspects of creating that conduit. I think in Peru we had a young boy with essentially he had an isolated left pulmonary artery and tetralogy of Fallot. He presented at the age of about 11 or so, and again, like Alistair said, this was indeed a true team effort. We had our CAF team with great resilience find that LPA, and we were able to incorporate that into the confluence or the RPA, and the kid basically, has been by the grace of God doing well since then. But again, I think it's a remarkable testimony to the way Heart Care International brings together all of this expertise to really make a significant difference in the life of a child. I'll also mention, even here in Saudi Arabia, I've personally had a few patients with Truncus Arteriosus who presented a little bit late. So Alistair, it's really interesting because our paradigm in the United States has been to operate within the first week or two of life, but we recently operated on a patient with Truncus Arteriosus with an interrupted aortic arch who presented close to about, I would say, 4 to 5 weeks of age. And granted, this was a concern for me, but it's interesting. When we did the procedure, the patient has done well, but the patient does require postoperative nitric oxide as well as sildenafil, like you said. So I don't know, maybe through the combination of all of these experiences, we may be coming to a new way to manage these patients, or maybe offer procedures for a broader range.
No, I agree with you. I appreciate the comments. Iris, is somebody who's worked in, in this with us. You've gone to Peru with us, in El Salvador. What can we do better to disseminate this information and help the management of these patients that might be late presenters? And your thoughts? You're muted. While she's thinking, I will actually go to Gloria to ask, we've been really looking to improve the outreach virtually, and you must see a lot of these patients in your ICU down in Peru. What are your thoughts of management and how we can help you more? Okay, she's muted. Nick, when we look at going to these places, how do we improve the perfusion and education so that, one of the issues in Chiapas is having a perfusion team, so that we can do these type of procedures? Nick's muted also. So I've asked my questions. Does anybody have any questions for the presenters?
Iris is back.
Iris, unmute yourself. I would like you to talk about what we can do. You've been with us in Peru, El Salvador, worked with us on this last trip, but these high-risk patients that we're doing with pulmonary hypertension, how can we expand the knowledge to take care of more patients? And your thoughts?
Well, I haven't been to Peru, but I have been to El Salvador, and I have been honored to be with you in several trips to Tuxtla. And we were talking about this last week, and I think it's important for many of these types of teachings. We need to have these types of reunions, like Zoom reunions, and this will expand the type of things that we can see. The resources that we have here are very limited. So most of the kids that we see will come late. We don't have that advantage of fetal echocardiograms on the mom. So most of the kids that we see here in our resources are late. They will come late to the hospital. And in my case, that I live 2 hours away from Tuxtla, what I've seen is that even we have 2 cardiologists that work with me. When we try to send those kids to another place, it's very difficult for them to be accepted, to transfer those kids. So the time goes on, and maybe if that diagnosis was early, they will go 1 month or 2 months later. And most kids that don't come cyanotic, they will go far, far away in time. So I think we need better education and better screening to prevent this type of things.
No, and I agree with that, but I think it really shows the tribute of innovation and taking care of these children. Again, as I said, we did 3 kids that had pulmonary hypertension this last week, and they all 3 have gone home and within 4 days. So either it's a different physiology or we're overreacting. And I think it's more a tribute to teamwork and coming up with a plan.
I think that we also have to work with what we have. We always are too limited. For example, we only have maybe milrinone, and sometimes we don't have milrinone, and only so then I feel so we have to work with things that we have. And most of the time, in other countries, there's a lot of resources or more resources that you say that this doesn't work, or I don't have this. You have, I don't know, 2, 3, 4 choices, and we have one. So we have to do that.
And one last thing, if anybody has any other questions, but before we hang up, if everybody can unmute their mics and wish Betsy a happy birthday.
Happy birthday, Betsy!
Happy birthday, Betsy. Okay.
Happy birthday.
Happy birthday.
Happy birthday, Betsy.
Feliz cumpleaños.
Thank you.
And we're going to sing happy birthday to her.
No, you don't.
Happy birthday to you. Happy
Happy
birthday
birthday to you. Happy birthday, dear Betsy.
Happy birthday to you.
Thank you.
Cha-cha-cha.
Thank you, Max. Thank you. Thank you. Ay, ay, ay.
Hi, Carol.
Ay, caramba.
Anyways, great presentation, amazing work, and I am so honored to be part of such an amazing group of people, and we look forward to a very successful trips coming this fall. We have 3 lined up already, and then we have a few in the